Buenas tardes
Hola.
y gracias a HL7 Argentina por la invitación por hablar sobre mi trabajo con los determinantes sociales de la salud o social determinants of health. Mi nombre es Evelyn Gallego, soy CEO de EMI Advisors y Program Manager del Gravity Project. Primero me disculpo por no poder darle este seminario en español. Admito que es difícil para mí traducir este tema en español, es nuevo. Yo soy canadiense, nací en Canadá. Mis padres son de Medellín, Colombia. Hablo español, pero claro, yo vivo en Estados Unidos en este momento, en Washington, D.C., y este es un tema que no he aprendido cómo traducirlo en inglés. Entonces, me disculpo porque voy a dar la presentación en español y si tienen preguntas me pueden avisar en español y voy a tratar de contestarlas. Bueno. Entonces, cambiando ya en inglés, here's our agenda for the seminar today. I'd like to start by grounding you on the why we are doing what we are doing before jumping into our work and accomplishments to date. I will end by sharing how you can engage in this work as we have other international countries also participating, does not need to be US focused. All right, so I start by my discussion with this image created by Dr. Laura Gottlieb with permission from Dr. Jack Maypole. It illustrates the challenge healthcare providers face today in treating patients. They often focus on the acute or health-related issues without considering the underlying social determinants. In this case, the social determinants include the availability of healthy food options and housing, access to educational and economic opportunities, transportation options, and exposure to crime and violence. Today, healthcare systems are poorly equipped to address these conditions because they often do not require a medical-based treatment or intervention. Over the last decade, SDOH has become such a buzzword, and this was way before COVID. SDOH rose to prominence in the healthcare space as the healthcare system began to shift. Again, American healthcare system began to shift from fee-for-service to value-based payment. So I want to start by grounding us on the definition, the actual international definition for SDOH. SDOH refers to as the conditions in which people are born, grow, live, work, and age, which are shaped by the distribution of money, power, and resources. They're described either as protective or positive forces or negative forces, which we refer to as social risks. There is growing awareness that SDOH information improves whole person care and lowers cost. We know that over 50% of our overall health is driven by socioeconomic factors and the physical environment. In fact, again, globally, only 20% of our health is driven by healthcare. Yet in the US, over 80% of our spending is for healthcare versus other areas. And I appreciate that this is not the same number in other developed countries. There is strong interest from health systems to address SDOH in clinical settings, especially as more healthcare organizations in the US are increasingly being pressured to produce better outcomes and more value per dollar they spend on healthcare. We know that again, the evidence shows that unmet social needs negatively impact health outcomes. The global COVID pandemic has only magnified this, as we are hearing more and more about the increasing health disparities as a result of unmet social needs. We have growing evidence that food insecurity correlates to higher levels of diabetes, hypertension, and heart failure. Housing instability factors into lower treatment adherence. For example, if you are homeless, it is hard for you to keep your asthma or hypertension in a refrigerator. We also know that transportation barriers result in missed appointments, delayed care, and lower medication compliance. And we know that addressing SDOH is a primary approach to achieve health equity. The value proposition for collecting and using social risk data is ever increasing. The Social Interventions Research and Evaluation Network, otherwise known as SIREN, S-I-R-E-N, which is the co-founder of the Gravity Project, encourage us to think of uses of social risk data in 6 areas. They encourage us to think of it to improve medical care, for social risk interventions, for population health management, for risk adjustment, again, to support claims and payment, for community health improvement. A lot of this I know does happen in, we appreciate that in the US, the healthcare and the social care systems are very siloed. In other countries, they are integrated. Many of them are one and the same system. Here, they are very siloed. So we want to be able to look at the data to improve what new community programs need to be in place. And last but not least, we need to use the data to inform research, right? How can we be doing things better? Because we have learned from evidence that we've collected in the field. But even saying this and seeing value or the business case around capturing this data, clinical systems have not been able to consistently and effectively address the social needs because of existing challenges around the capture and exchange of this data. So this includes challenges around consent management, standardization of the data collection and storage, data sharing between ecosystem parties. Again, this is may not be prominent in other countries where the health and the social or human services sector are very integrated. It is a problem here. Access and comfort with digital solutions is another challenge area that's very global in nature. Concerns about information collection and sharing, that's a global challenge. Social sector capacity and capability, that's also, I would say also globally, because, again, most resources are put towards healthcare than social care. And lastly, there's unnecessary medicalization of Sdoh. This is very prominent here in the US, where the social care sector doesn't want the health sector to tell them how to do things or think that all that they're delivering is based for medical care. So let's focus on one of the challenge areas, which is around standardization of Sdoh data. So why would health system want data to be coded or standardized? They want this because they want to promote the collection and use of the data, right? So across all the health systems and with other community-based organizations, right? They want to be able to know how to speak the language of and be able to share data. They want to facilitate sharing of the data across these organizations. And also very important here in the US is they want to facilitate payment for social risk data collection and interventions activities. Many of this right now is not paid by the healthcare system. Again, I would say the clinical by current health plans and federal funding. There are other programs that support this, but again, not within the health programs. So this brings us to an investigation that SIREN did in 2018 to look at what actually codes existed to represent this data in electronic health records. So they looked across the 4 leading terminologies of ICD-10, SNOMED-CT, LOINC. These are international terminologies. CPT is very much, is another coding terminologies, but it's not open source, and it's through the American Medical Association. Again, it's not a global code. So what they found is that there were over 1,095 codes available to represent this data across 20 social determinants of health domains. But what they found is most of the data was for, as you can see here, 686 for diagnoses codes. The rest was limited. They also found that there was an overlap of codes in some areas, and most importantly, a lack of codes available to represent data concepts. So this brings us to the Gravity Project. The goal of the Gravity Project is to develop consensus-driven data standards to support the use and exchange of Sdoh data. We're focused on developing data standards for the multiple domains you listed here. To date, these are the 14 domains we worked on. And when I talk about domains, it's food insecurity and so forth, like housing instability. These domains are grounded by the domains proposed in the 2014 National Academy of Medicine report. The link is there at the bottom. They actually provide guidance to the US federal government on what are those domains that need to be captured in electronic health records to support health equity efforts. So we launched the Gravity Project as a public collaborative in May of 2019. Our scope initiates with developing, testing, and validating standardized Sdoh data for use, not only in patient care, but for care coordination between the health and human services sector, for population health management, for public health, for value-based payment, and for clinical research. We are developing these data standards to represent patient or individual level data documented across the 4 clinical activities. And that's what you see the visual on the right, for screening or assessment, for diagnoses, for goal setting, and for treatment and interventions. We do all our work by convening a very large public collaborative of now over 2,000 participants from across the health and human services sector. These includes entities coming not only clinical, but other community-based organization, government, other standard development organizations, health plans or payers, technology vendors, and the international community. We actually have representation from Canada, the UK, and Australia, and we welcome participation from Argentina. We convene everyone bi-weekly, every other week, from 4 to 5:30 Eastern Standard Time. All are welcome. It is open, it's free to join. You don't have to be an HL7 member. I think that's part of our value of our work. We've convened entities that never just heard about HL7 for the first time, did not know what FHIR was, and so forth, or what a new code was, but they've come to the table because they want to be able to participate in this work. The Gravity Project is not an entity. We are a project that's funded by multiple organizations, including the federal government and health plans. So here's just a snapshot of our current sponsors. We describe our work as 2 active work streams: terminology, where we work on defining data concepts for multiple Sdoh domains, and our technical, or where we've been focused primarily in developing FHIR implementation guides. Although both work streams function in parallel, they interact in the center in the publication and use of the coded value sets. I will speak to these work streams more in the coming slides. Here's just a quick snapshot of our timeline. I want to acknowledge we initiated our work in 2017 when SIREN, as I mentioned, the Social Interventions Research and Evaluation Network, started investigating, and the research noted that there was this problem that needed to be solved. So they convened 50 individuals from across the health and human services. This ad hoc committee determined that a public collaborative was warranted, and then we began initial work in 2018 and formally kicked off, as I mentioned, in May of 2019. We started on the first domain of food insecurity. In August of 2019, here in the middle, we became an HL7 FHIR accelerator to ensure our work helped to advance the use of the FHIR specification for Sdoh data exchange. In 2020, so last year, we shifted from working on 1 domain at a time to working on multiple domains to get us to the 14 we've had developed to date. In 2020, last year, we also began to work on start our work on the HL7 FHIR implementation guide and began testing the components of the implementation guide at HL7 FHIR Connectathons. For 2021, our focus has been on the completion of these 14 domains and the publication of the FHIR IG, and I'll talk more about that in the coming slides. Here's a deeper look at our roadmap for the last quarter and into next year. Here you see us completing the domains in the November timeframe. We have 3 work streams listed here. We will focus our next efforts on actually building new codes for these domains we just completed and doing more targeted dissemination. We need to better educate the community at large on what we've developed to date. So we've factored in some time for that. And last, we need to be able to test. So we are looking to test, and this is where our pilots come in. Next year, we assume we will start on 3 new domains, the February timeframe. We're currently working with our governance committees to determine what that is. And then we'll go through another build and dissemination and test activity, and then start 3 other domains. On the FireIG side, we are getting ready to ballot version 2 of our FireIG. We published our STU version 1 in August of this year, and we are updating for a version 2 to ballot in the December-January cycle. Next year, we will focus on testing that FireIG with our pilots and going through ongoing Fire Connect-a-thons, and then we will launch our pilots where we'll actually be testing in the field the balloted STU version 2. All right, so a deeper look into terminology. So every time we start a domain, and as you'll see, we go through, we organize data across those 4 activities I mentioned of screening, diagnosis, goal setting, and interventions. And every time we start a domain, we ask ourselves 3 primary questions. What concepts need to be documented across those 4 activities? And when I talk about concepts, they're data elements, but really it's the language. What is the language we need to use, right? What is the language we need to use to represent these activities? Once we have that language or those data elements, then we ask ourselves, what codes exist to represent this data in electronic systems? And what codes are missing? And what you see on the right-hand side is that the codes are very representative of the activity. So LOINC is used to represent screening and goals data. ICD-10 is to represent diagnoses data, and SNOMED is used to represent goals and interventions data. Here is a snapshot of what this looks like for the food insecurity build, food insecurity being one of our domains. So in the interest of time, I won't go through each of these, but it really gives you an example of what I mean by a data element, a coded data element. So just using LOINC, the first one, the screening question answer pair, you will see that the question has a representative code. So the question within the past 12 months, we were worried our food would run out before we got money to buy it. That has a specific LOINC code. And then the answer, the values within often true, sometimes true, never true, don't know, also has a representative LOINC. And we see this across all those 4 activities. Part of our terminology work was creating a structure, working directly with SNOMED CT, for collecting and defining these interventions. So we identified 9 overarching interventions, each of them again coded by SNOMED. So interventions around assistance, coaching, coordination, counseling, education, evaluation of eligibility. So this is also very US based, evaluation of the value of expected for the activity, provision, very tied to procedure or orders, commonly used in the health system. And then last but not least, referral, because most of these interventions are completed outside of the health system and therefore require the health system to make a referral for the individual. We appreciate that finding this information is not easy. We acknowledge there's a link here. We have a dashboard. So on this dashboard, you see all the 14 domains. You get a status of where they're at, like what data concepts have been developed, what new codes exist for them, are they published, or what's in the queue. So it gives you a sense of what's coming up. And we updated every time a coding steward like Regent Street for LOINC, SNOMED, and ICD-10 make a publication, these links and spreadsheets are updated. We want to acknowledge that last year, the Gravity Project made a formal submission to the ICD-10 Coordination Committee on data definitions to represent SDOH diagnoses or Z codes for specific domains. On October 1st, 3 of these domains, education, food insecurity, and housing, were published. So they're available right now. They exist. They can be used. I know this is US based, and again for ICD-10, but they're available. And we're currently working on updating. We just submitted for next year's, the ones that will be published for 2022. Our work within terminology is grounded by data use principles for equitable health and social care. We want to ensure that the work that we do as we create new standards and encourage the capture of this data in the field, we do not want to create additional health disparities for the most vulnerable population. So there's a link here and you could review it. And I apologize, it's in English. So let's move on to our technical work stream. So I'm assuming you all as HL7 Argentina are very familiar with what FIRE is and how FIRE IGs are created. So I just want to acknowledge that we do have one IG. It's called the Sdoh Clinical Care Implementation Guide. I mentioned it was published as a standard for trial, STU1 in August of this year. The FIRE IG incorporates all those clinical activities for assessment, health concerns, goals, interventions, consent, and aggregation for exchange and reporting. And I'll explain that in more detail. So within the FIRE IG, there are 6 overarching use cases or activities. So the first one is around documenting. Number 1 here is, again, applying that overarching 4 activities. It's around documenting the Sdoh data as part of a patient encounter. So think of the story of the patient going into a clinical office or into their doctor's office and completing a screening questionnaire, and then having the physician or provider review the answers and come up with an observation, and then have a diagnosis. So the FIRE IG describes how you can do this all electronic and automated, right? So it's within the FIRE IG. The second use case is once the diagnosis is identified, the provider and the patient, or the physician, the clinician and the patient, work together to establish goals. So this is where the social risk then becomes a social need, because the patient is acknowledging they need some support from the health system to address it. The third use case is with the patient and the provider working together to identify the interventions that will help achieve the need needed. And then this fourth activity is around measuring the outcomes of the identified intervention. The fifth use case is really when we look at, once you've done this, how do we consolidate, aggregate this data so for upstream and downstream use? So this is really where individual level data, because it's captured in a structured and standardized way, can easily be aggregated for analysis, right? Or for upstream, meaning, for population health, risk adjustment, public health, quality reporting. So this is where we look at how do we aggregate this data or create cohorts of patients. And last use cases around managing patient consent across all these activities. So bringing up to how do we develop data capacity? So how we accelerate the adoption of these nationally recognized standards is by incorporating the standards we use to define the data, or the semantics, what we see here on the left-hand side, into the standards we use for syntax or structure and transport, which is the FIRE specification. Each of these coded data concepts across those 4 activities I've gone through of screening, diagnosis, goals, and interventions are represented in the FIRE spec. So this is the slide I just presented previously. But the goal is really to integrate this work into other standards, or other evolving standards that are being carried out by other FIRE accelerators and ongoing HL7 work. So we're working very closely with the Argonaut project that is responsible for developing US core FIRE profiles to align with US CDI, the ONC US core for data interoperability. We also work very closely with the Da Vinci FIRE accelerator that's working on payers and provider data exchange, as well as Karen that is working on patient or consumer mediated exchange. We have ongoing connections with the Clinical Interoperability Council, and then we're working with our other FIRE accelerators, Codex, Vulcan, and Helios, that each have their own use cases but can build on our work. So this is ongoing and our target for most of our work for next year. Accomplishments and success factors. So in the last year, we've accomplished much, I say significant headway as a standards project, but even with all our accomplishments, and the growing interest and international interest in Sdoh data standards, how we measure our success comes down to how these standards we are developing are integrated and used across these 7 areas. So we start with policy. Again, we are US based, but this is something that's applicable across globally. Incorporation of the standards and payment models. This is very US centric here. In programs, again, these are US centric programs. Other standards, these could be international and global. In grants, this is where the federal government or state or any, has grant programs and they can incorporate, and I'll give an example. Where we need to do more is at the practice. So how can these standards be be part of a repeatable process for adoption, implementation, of use of the data, of Sdoh data at the practice level? And by practice, I mean in the doctor's office, right? How can we ensure that they can capture or have this commonplace, just like they capture clinical data and lab information, they also capture social determinants of health information. And last but not least, we want to inform or influence new innovation in the market, new tools for capturing, aggregating, analyzing, and using the data. I know, again, we are US, this is very US centric, but I do want to acknowledge that the gravity standards were incorporated in US policy in July of this year with the US ONC Office of the National Coordinator incorporating the Sdoh data activities around screening, diagnoses, goals, and interventions are in US CDI. So why is this important? With this, again, from a US perspective, health IT stakeholders have now direction towards standardizing the electronic exchange of Sdoh data. Again, before this, they didn't know. Everyone's capturing Sdoh data differently or creating technologies to support the capture of this, all doing it without clear direction. This provides clear direction. On the health clinic or system side, it lays the foundation for the clinical communities to start capturing and using this data in clinical settings and also adopting or buying technologies that can help them do this. So again, it's a signal. Soon it will become a requirement, but it needs to be in US CDI version 1 before health IT or certified technology is required. From a grant perspective, we have actually just summarized, there's 3 existing federal grant programs right now. I won't go through these in detail because they're very US based, but it's an example how the federal government here has incorporated the standards into requirements. So for entities to receive this money from the government, they have to demonstrate the use of the standards. And then, so how to engage? So regardless of policy drivers, right? So this is, again, I talked about American policy, but within Argentina, you may not have any policy right now to adopt the standards. We can still encourage health systems to play a role in incorporating the Sdoh data standards via incentives. So first area is health systems can reward vendors like health IT, like EHR platforms and developers to work together to integrate and use data standards. Health systems can also establish purchasing, group purchasing organizations, right? So they can partner with other entities to create common requirements for interoperabilities in the RFPs or requests, so in the contracts they release. Health systems can also embed in provider workflows the requirement to exchange bi-directional exchange of this data. So it's not only being pushed by the health system, but having a way for data moving back and forth. And then lastly, the health system can incorporate this in workforce education and standardization of data. So again, for training of the clinical and human services providers. So lastly, I'll leave you how you can join. It's free to join. You don't have to be an HL7 member unless you want to vote on a ballot going through the HL7 process, but you're all welcome. We have a public work group where we talk more about the terminology that meets every other Thursday. And we have a Fire IG work group through HL7 that meets every week. Again, I mentioned we do have international participation, and they both join these work groups. And I leave you with our team's information. This is our program management office. Welcome, happy to answer questions, and in Spanish too, I will do my best. Please reach out. Thank you very much.
Bien, bueno,